Hi, everyone. Welcome to See Arthritis at the Canadian Rheumatology Association and Arthritis Health Professions Association Annual Scientific Meeting. I'm Maya, I'm the program coordinator at Arthritis Consumer Experts and also a person living with rheumatoid arthritis. I'm joined today by Dr. Carl Laskin, who is an associate professor of medicine, obstetrics, and gynecology at the University of Toronto and on staff at Mount Sinai Hospital. He is also the managing director of Trio Fertility in Toronto and an internationally recognized expert in the specialized field of reproductive immunology and autoimmune diseases in pregnancy. Thank you so much for being on our program today, Dr. Laskin.
My pleasure.
So I did do a brief introduction there, but I'd love if you could just tell us a little bit more about yourself and how you are involved in rheumatology.
Okay, I always like to start off when I do a bio on myself saying that I was born at a very early age, but I've not been in rheumatology for most of my childhood and teenage years. Rheumatology was something that captured my interest when I was I guess it was a second year medical resident, and I was at Toronto General Hospital at the time, and it captured my interest I therefore decided that was the direction I was going to go. And I've been in rheumatology now since certainly before you were born, and on staff first at Toronto General Hospital. I did fellowship training after my rheumatology training at the National Institutes of Health in Bethesda, Maryland, before they put up the fence with the spikes on top, and then back in Toronto on staff at both Toronto General and Mount Sinai Hospital, and then what became University Health Network, and have continued practicing rheumatology. I practiced general rheumatology in the first few years of my return, became interested in lupus and pregnancy and recurrent miscarriage. And it's the whole area of recurrent miscarriage that got me involved in the pregnancy aspect of things. And my practice evolved into where it is now, a large practice in medical management of pregnancy in women with rheumatic disease, but the pre-pregnancy evaluation is both in women and in men with rheumatic disease, and particularly with the medications that people are on. That in around 1990 moved into dealing with actually 1987 I was taught management of infertility, and in 1990 I kept going the skills in managing infertility, and learned how to do IVF. So I dare say I am sure I am the only rheumatologist in the world that actually does IVF. And my practice is probably a much greater proportion of the management of rheumatic disease in pregnancy. I would say that forms the bulk of my practice.
Right, thank you. And so then focusing on the topic of pregnancy and rheumatic diseases, I'm wondering if you can share with us what are some of the key factors that are important for patients and their healthcare providers to consider when thinking about pregnancy?
I think what's really important is a pre-pregnancy evaluation. First off, when I lecture on this, part of my lecture is every rheumatologist should be talking to their patients at least once a year, to those women that are in reproductive years, about pregnancy. Ask them, are you considering a pregnancy? You don't want a surprise with the woman on drugs that are toxic in pregnancy knocking at your door for an assessment. It's wonderful news, I'm pregnant, but not on the best drugs. You don't want that surprise. And the best way to ensure you don't have it is make sure you discuss family planning at least on an annual basis. And when you discover that the woman or the couple are planning on a pregnancy, a pre-pregnancy evaluation needs to take place. The attending rheumatologist may be comfortable doing that evaluation, or refer to someone that is comfortable doing the evaluation. Could be a rheumatologist such as myself that does this. I have a number of excellent rheumatologists that I train that are scattered across the country that can do it. Or you have the patient assessed by an internist who specializes in what's now called obstetric medicine, that is medical problems in pregnancy, or if it is an obstetrician that does high-risk pregnancy, and those are called maternal fetal medicine specialists. In any case, the point of it is a pre-pregnancy evaluation is, I think, critical. You get the patient set up, you get them on pregnancy-safe medications, and you want them in the best possible shape they can be in to go forward in a pregnancy.
Right. And in terms of that pre-pregnancy evaluation, let's say if the doctor hasn't done that annual checkup, when should a patient approach the doctor to have that conversation? So essentially, how far in advance before planning to conceive?
As soon as they are thinking about it.
Right. Okay. Nice and clear. So in your presentation, you used this really interesting framework, the red light, green light, yellow light framework. And in that, so I'm sure you can do a better job of explaining this, but the red light category was pregnancies that you would consider to be too high risk, essentially. And what I'm wondering is if a patient's risk factors can change over time, like if they're considered too high risk now, is it possible that at another point they may be able to?
Oh, absolutely. And a lot of the red light, that is, this is not the time to go through a pregnancy. You have to have a very difficult discussion about terminating the pregnancy, and that is a very difficult discussion. But I would say probably the biggest reason for the red light are the drugs. They happen to be on the wrong drug and they get pregnant and they've got too high a risk of an abnormality occurring in the fetus. That is probably, if that's not the number one reason, it's the number two. Number one reason or number two reason could be because their disease is just so unsettled. It's too active. It would be, they would have to, it'd be a lupus patient with major organ disease or some other rheumatic disease that has involvement of kidney or heart or something, where I would say this may be a pregnancy you want to, let's stop this pregnancy now. It's just too dangerous for you. Those would be the conditions. Now, if you're looking at both those conditions, things can change. So I may give someone a red light in the month of March, we'll say, and I would bring them back 3 or 4 months later and reassess the situation. One, their drugs may have changed. Two, the disease may be under better control, in which case you could give them a green light. The toughest one I would say from a clinical perspective, the most difficult one of that red light, green light, yellow light is the yellow light.
Hmm.
And that really is the patient arrives on your doorstep pregnant. You look at them and say, well, it would not be something I would have advised, but let's work with it and let's see if we can't get through. And this would be someone that has, say, some disease activity, or they stopped a pregnancy, a drug that would be considered toxic in pregnancy, like methotrexate. They didn't stop it the full 3 months before. They stopped it maybe 2 months before. Those are ones that you have to have a discussion about termination. Most women would not terminate under those circumstances. And those are ones where you just have to go through a number of assessments before that would present more of a yellow light. So they're not ideal candidates for a pregnancy at that moment, but you would carry on with it. I would go forward, definitely be in a high risk pregnancy setting, and I would manage them accordingly. And I would say that most of those patients actually make it through.
Right. And in terms of the drugs that are most toxic for pregnancy, what are those for our patient audience to be aware of the drug?
Methotrexate is one. Uh, Mycophenolate, that is abbreviated MMF, or Cellcept, or Myfortic. Those are the big ones. Cyclophosphamide is, that would be, we don't use it nearly as much today as we used to. That also should be, that's also a contraindication. Um, High doses of prednisone. When you're getting prednisone, like above 20 milligrams, you gotta, would I terminate for that? Unlikely. But when they're on higher than 20 milligrams of prednisone, clearly the disease is active. But I think the drugs I mentioned, Cellcept, Myfortic, methotrexate, and cyclophosphamide, those are the drugs that for sure are ones where you're going to talk termination.
Right, right. And it's okay to be on those, right? Like it's at some point, it's not going to impact your fertility per se. It's just not while you're pregnant or
Well,
trying.
cyclophosphamide can impact fertility.
Okay,
The other drugs will not, but it's a matter of being off them for an appropriate length of time.
right. Thank you. Yeah, I hope that our patient audience, including young women like myself, can hopefully can spread that information to avoid those red light situations where then you have to have that conversation about termination. So now this is actually a question that we received from a member of our patient community. So they are a mother themselves who lives with rheumatic disease. And they asked, are there any interdisciplinary care teams in Canada or other resources for supporting moms after giving birth? So during nursing, parenting, and managing a postpartum flare-up?
Well, postpartum flare should be managed by their attending rheumatologist. That's number one. In terms of the support groups in those areas, those are usually linked to the hospital obstetrics and gynecology department, to the birthing units. So in terms of from a rheumatology perspective, I don't know of any in Canada that would support that. I think that the uh, postpartum flare, that's particularly in a rheumatoid, that's the attending rheumatologist.
Right. And so that is something that patients should feel comfortable seeking out that support from their
Oh,
rheumatologist.
oh, absolutely.
Great. Yeah. And then my last question for you is if you have any final pieces of advice or words of wisdom that you can offer women with rheumatic disease who are thinking about having children.
I guess I draw upon an example that happened many years ago. It was a patient that was referred to me by another fertility unit who was undergoing fertility treatment with them and developed basically joint pains. And nobody was sure what it was, and they wondered if it was the injectable fertility drug that was doing it. So they punted them over to me, and I went through everything with her. Nothing, there was nothing in the history that would lead me to believe that that was the case. I was well aware that some women would get some joint pains associated with this medication that would go away quickly enough, but I thought this was a little too pronounced. And that was it. As she's leaving the exam room, she turns around and says to me, "Do you think this could be my lupus?" At which point I brought her back in the room. I said, "You better sit down." When I asked you the question about did you any arthritis in the past or anything, she says, "I didn't want to say anything." And why didn't she want to say anything? Because she thought her rheumatologist would be upset that she was going through fertility treatment. So I called her rheumatologist and I spoke, and I had permission. I talked to the rheumatologist about this, and she says, "Unbelievable. I can't believe she's having a flare. I'm aware of it." She has not had a flare in years. What, I don't know what the heck is going on. What are you seeing it for? When I told her what it was, the rheumatologist said to me, I really wish she would have told me. I could have prepared her for this and we could have been taking care of things. So I think the thing that is important, and I am well aware how important starting a family or growing a family is to many individuals, many couples. I'm well aware of that. If you have an underlying medical problem, get your medical specialist involved before you go forward in a pregnancy. Go into that pregnancy with all the people that are helping to take care of you, know about it, know how best to manage it, do the pre-pregnancy assessment. There's no secrets. The other thing is, when you have to go see your medical specialist, and I don't care what the underlying disease is, whether it's rheumatic disease or whether it's heart disease or inflammatory bowel disease, I don't care what the disease is. You get your specialist involved. And when you're there to discuss pregnancy, and you ask, is it okay? Do you think it's okay to go forward? Have your partner in the room.
Mm.
And the reason I think it's important to have the partner in the room is many women will take risks with themselves to have this potential child. And that's because in the case of many women is that close to 100% of their emotional investment is having this child. Whereas their partner, close to 100% of their partner's investment is in their partner. And I want somebody there in the woman's corner who worries about the woman and is it safe for her to do this? And that's why, so I think that's important. Anybody that's involved with you, get them as part of your plan. And I think that's the way to be safe. And that way everybody walks into this with their eyes wide open. So that would be my advice to anyone contemplating pregnancy, and discuss it early. So with rheumatic disease, discuss it early. Make sure the drugs are safe. If the drugs have to be changed, they'll be changed. There's a certain period of time. Methotrexate is 3 months. Cellcept is 6 weeks. Cyclophosphamide is 8 weeks. But there's other things you got to look for when you're on those drugs. Cellcept and Myfortic are very similar drugs, same family. Again, it's 6 weeks. But you just don't cut it too close there, okay? But when you're planning it, plan it so that you walk into it in a smart way. You want to get pregnant, and you want to get pregnant safely, and you want that pregnancy going forward safely. And that's why you get your medical specialists involved.
Thank you, Dr. Laskin. That is very important advice. And I think especially about making sure the partner is involved and thinking about your well-being when your focus is probably on the baby's well-being. So that's definitely really, really important advice. Thank you for sharing that with us. And thank you for being on our program today to
Oh,
talk
my pleasure. Thank
about a
you
very
very
important
much.
subject.
Okay, right. Bye-bye.